Okay, so can you see the screen? All right, so thank you everyone for joining us today. I know it's everyone's lunch hour, or maybe you're joining us, while you're on holiday, but we are here today to give you an overview on what North Carolina Medicaid expansion will have on postpartum and maternal health care. So I am Velma Taormina. I am a board certified OBGYN who clinically works in local health departments, and I am currently working with the Mecklenburg County Health Department as one of the medical directors overseeing their family planning and BSEP program. As a women's health consultant, I am a paid consultant to North Carolina's Division of Health Benefits, otherwise known as North Carolina Medicaid. So I am here today with Dr. Rachel Urrutia. I practiced your name over and over. I will let her introduce herself, but Rachel, thank you so much for joining us, because I know that you had to leave your family while on spring break, and we appreciate you being here.
Yeah, no problem. I agreed to do this before we had all our things planned. So Rachel Urrutia, I am also an OBGYN. I am also board certified in preventive medicine, and I do clinical medicine at UNC, general OBGYN, labor and delivery, and seeing patients in clinic, but I also do research. And for this talk, I'm wearing my DHHS hat, where I receive some salary support, and I am the women's health medical consultant at the Division of Public Health Women, Infant, and Community Wellness section. And Velma has taught me most of what I know about Medicaid, so I always like hearing her talk, but here also to talk maybe more on some of the practical side of questions that I get asked from local health departments and otherwise about coverage and things like that.
All right, so our objectives today are pretty simple. Our goal is to expand your fund of knowledge on Medicaid expansion, specifically in North Carolina, and its impact on postpartum and maternal health care in our state. So I want to make sure that everybody has the same basic knowledge on what Medicaid expansion is. As Sarah alluded to, yesterday was our 1-year anniversary on the date that Governor Cooper signed into law the ability for North Carolina to move forward with Medicaid expansion. So that occurred on March 27th, 2023. And then on September 25th, Governor Cooper and Secretary Kinsley announced that Medicaid expansion would become effective on December 1st, 2023. So if you think generically of Medicaid, most of us just talk generically that it is a program, but it really has lots of different subgroups. So this expansion group is a group of individuals that have to meet the annual income criteria that you see on the bottom. And the nice thing about this is that historically, there were different categories of either you had to be a child, or you had to be a woman, or you had to be elderly. But in this case, this is looking specifically at single adults. I mean, it also includes single adults. But you have to live in North Carolina. You have to be between the ages of 19 and 64. You must be a citizen, although some non-US citizens can get health coverage through North Carolina Medicaid. And then your income has to fit into this chart below. So it's an expanded group in addition to what was already in place. So it's only been in place for 3 months, so we can't talk about what kind of long-term impact this has had, but we do know by looking at the data that we have from the first 3 months that this is benefiting North Carolinians that have no health insurance. More than half are under the age of 40. Most are employed in industries that are crucial to the economy. 1/3 are parents of children. More than half are women, and they represent all races and ethnicities. I like to share this slide with individuals because, again, as I alluded to, a lot of times when you're talking about Medicaid, you're thinking that it's one generic program. But what these 3 pages show you is that there's actually now 22 if you include the expansion group, different types of groups that somebody can be eligible for. So you can tell by looking at the paperwork that it's a complex system. And our take-home message, as part of our conversation today, I don't want you to sit there and think about whether someone is eligible, or if they are eligible, which of these programs would they be a best fit for. I just want you to encourage individuals, specifically if they are uninsured or underinsured, to apply for Medicaid and to let the computer algorithm decide which of these groups best meets their needs. And we've put links on all of this. Almost all of the information today is going to be available through public-facing websites so that you can go and, drill down on some of this information at a later date. So when you look specifically at the individuals that this group is working with, we're either working with those that are pregnant or soon to be pregnant or postpartum. So when you look at the impact on maternal health, Medicaid expansion did not directly increase coverage for during pregnancy in North Carolina, because the income limits for pregnancy were much higher than what this expansion group is. So if you think of the expansion group being those that have income levels that are up to 138% of the federal poverty level, or FPL, in pregnancy right now, those income levels are much higher at 196%. But it's the benefits that are going to occur before they conceive, or between pregnancies, or after they've completed childbearing, where we're going to see the majority, where we're hoping to see the biggest impact. So again, we've listed just a few of the things that could be considered there. And it's, if somebody has an existing chronic condition, then they'll be able to access medical care to help stabilize that condition before they become pregnant. It's going to improve finances because they're now going to have a funding source for their health care. And then, as we know, the individuals that we care for are generally taking care of, other family members or the elderly, or just, they are caregivers. And this is going to improve their basic healthcare status. The exciting part of this for me anyway, because I live in the family planning's Medicaid space, is that because family planning Medicaid is, okay, let me back up. So family planning Medicaid is another type of group of individuals that have Medicaid, but it's a limited benefits program. But as you can see here, the expansion group's at 138% of the federal poverty level. Family planning Medicaid recipients can be up to 195% of the federal poverty level. So because these individuals were already part of the Medicaid family, Medicaid staff were able to automatically move them into this expansion group behind the scenes without these members having to do anything extra on their own. And, which means that about 260,000 members were automatically moved from family planning Medicaid into the expansion group. They were auto-enrolled into one of the health plans or into Medicaid Direct. And literally at midnight on December 1st, these members were able to receive full benefits. They were notified of this in a variety of manners in the month of November. So we know by looking at prescription and paid claims that many of these individuals are already accessing care. So this is important, so I've highlighted just a couple of things here, but what I'd like Rachel to do now is to give us an overview on why we think this is going to be beneficial to the members in our state.
So I just wanted to summarize a little bit of what we know about the data about Medicaid expansion, because we in the United States kind of had a natural experiment in the last decade, because of course there were many states that did expand Medicaid and others that didn't. So researchers have been looking both at pre-post expansion in the same state, but also comparing outcomes between states that did and didn't expand Medicaid. I'm looking at a variety of outcomes. This slide is from the Kaiser Family Foundation. I copied it directly because they did a systematic review of the studies, although it wasn't published in a peer-reviewed journal, but the link is here. And they summarized all of the information as of 2023, so it's pretty recent in terms of studies that have looked at maternal health benefits. So there were 8 studies that looked at coverage, and interestingly, even though, as Dr. Taormina discussed, I'm not sure if maybe someone needs to mute. As Dr. Taormina discussed, there actually isn't increased eligibility during pregnancy, but some of these studies even found that there was more insurance during pregnancy in the states that expanded Medicaid. And but there was also increased insurance coverage prior to conception and also postpartum and post-abortion. So that speaking to that potential ability to manage conditions between and after and before pregnancy. Looking at specific maternal and infant health outcomes, there were 18 studies. And in general, the studies definitely showed an increased access and utilization of both prenatal care and postpartum care. So people knowing they already had Medicaid, right? And we know in this state, anecdotally, that there are lots of delays around. I didn't even know, I had to wait until I had Medicaid, right? To start my care. And so you can imagine that if people just know that they're eligible for Medicaid because they already have Medicaid, then they're going to potentially seek care earlier. And maybe already have a place of care, right, that they know they can get care from, so they don't have to establish as a new patient. They also showed improvements in some birth and postpartum outcomes, but no effect on others. And I'll dig deeper into this on the next slide. In terms of family planning, there were 11 studies that looked at this. And if you go to this article and you want to look at each of the individual studies, they're all cited there. But there was an increased use of more effective contraceptives, such as LARCs, but an unclear impact on birth rates and short interpregnancy intervals. For HIV care and prevention, there were 6 studies, and there was increased coverage for people at risk of or having HIV, as well as increased HIV testing and access to care. So you can do that. So this is kind of their deeper dive looking specifically at those maternal health outcomes. So there was one study that found that expansion was associated with a significant decline in self-reported pre-pregnancy depression. There was one study looking at maternal morbidity in New York. And this study has gotten a lot of press, but it's admittedly one study, and there are others that didn't show this. But anyway, New York found a significant decrease incidence in maternal morbidity. And this decreased incidence, so pre and post Medicaid expansion, and this decreased incidence of maternal morbidity, so like severe maternal morbidity, was actually greater for low-income women, right? So there's kind of a disparity there according to socioeconomic status. And so it disproportionately benefited those who had lower SES, or lower insurance status, which makes sense. And then there were improved infant outcomes at birth in 2 studies showing lower rates of infant mortality, especially among Hispanic infants, and one that showed decreased low birth weight in people that had hypertension. And then also a study that found that Medicaid expansion reduced racial and ethnic disparities in infant health following rural obstetric unit closures. But there were a number of studies, I think 7 here, that didn't find any impact on certain pregnancy or postpartum health outcomes. And so I just want to note that this, it's not like going to fix we know it's not going to fix all the problems in maternal health, but we do think it has potential to improve a lot. And I think that it's also these slower types of outcomes, right? Like you're not going to see the effects of better management of chronic conditions, possibly for several years, maybe even for 10 years, right? If somebody delays childbearing. So next slide. There have been a few studies since then published. I just wanted to highlight, there was one in Health Affairs this year that showed 17% less hospitalizations in the first 60 days postpartum in Medicaid expansion states, and smaller decreases in the later postpartum period. And then a study, again, in health economics this past year that didn't show any impact on maternal morbidity or specific indicators of morbidity. So next slide. I think it's back to Dr. Taormina.
All right, so this would be a good place to take a break on just to see if we have any questions. Is there anything we need to address just as we review the background of Medicaid expansion?
I don't see anything in the chat. Folks, anyone have a question you want to ask? If not, you can keep going and I'll keep my eye on the chat.
Okay, sounds good. Okay, so one of the things that we referenced was that when individuals were assigned to this expansion group, they are added to one of the standard plans. So if you recall, back in July of 2021, Medicaid underwent transformation where we moved from the fee-for-service to this managed care world that we're in now. So on the left is a chart that was released at that time. So when someone is enrolled with one of these standard plans, they have medical care coverage like they had in previous fee-for-service programming. But what these standard plans can now do is they can provide added services, which traditional Medicaid and Medicaid Direct cannot do. So this is another area that I really want to keep expanding, knowledge especially when I'm talking to audiences like this, because many of our members, even though they've been informed that they have these added services, they're not always familiar with what they have to do to get them. They're not automatic. I call them added services, that you may see them listed as additional benefits or supplemental services. They could be a variety of things, but basically, these are the 5 plans. And if you go to any of their home websites and look for added services or additional benefits, then you will see a whole listing of things that are available there. So as you know, over the last few years, North Carolina Medicaid has specifically worked on not just improving health care delivery, but also health. And we know that there are a variety of other things that impact someone's health status. So all of these plans have a wide variety of different things that they offer under these additional services. Everyone includes something on education, some in the prenatal space, some in the non-prenatal space, wellness as a whole. There are some benefits that are available just to those under 18. So the chart on the left is what was in place back in 2021, and this changes. So as a provider, what I would encourage you to do is to at least educate yourself, number one, to know that these added benefits are there, and then to educate yourself about, let's say that your practice, the majority of your patients are under Healthy Blue. Well, at least go to the Healthy Blue website and look and see what they offer, so that when you're engaging with those patients in your office, or if you're out in the community doing community work, when you're interacting with someone that has a potential need for these services, that that you can refer them to this. I don't expect you to be an expert in this. I happen to look at these on a quarterly basis just because I'm just interested to see, and I honestly don't know how often they change. But on the right, I highlighted WellCare's additional benefits. So again, all I did was Google, North Carolina Medicaid WellCare, and I got to their homepage. On the left side column, there's a tab that says additional benefits. And when you expand that, there's a whole listing of things that are available for their members. So again, if you have somebody, I am always focusing on education. If I see that somebody doesn't have a high school degree, then I will inform them, hey, do you know that your standard plan offers assistance to help you get your GED? They all have a variety, and WellCare specifically has up to $450 worth of different rewards for baby
Yes, we could go
products.
there, huh?
There are gift cards that are available. There's discount cards. If you have a high-risk pregnancy, they have a doula program that's available to some of their members. When they're not pregnant, there's a Weight Watchers program. And if I believe the last time I looked, I believe all of them have some type of a voucher system for that. And having been through Weight Watchers at least two times in my lifetime, I am a huge fan of that program. So I was very excited to see that happen. And we know that we have members that have communication barriers. So they may not have a cell phone at all times, or they might have a cell phone, but they have limited data, or they, may struggle with that. So some of these plans offer cell phones that have data plans with them. And then they all offer assistance with transportation. If they're going to a medical appointment, that's covered. But then some of these plans also offer transportation assistance, say if they're going to their YMCA or to the Boys and Girls Club. So there's lots of information there. And again, I'm not asking you to become an expert in what those individual items are, but I want you to educate yourself about how to help someone else get there. One of our colleagues just reached out here in the last 2 weeks, letting me know that, even with her knowledge set, that it was hard to navigate the system, and that when we're working, and just highlighting the importance of knowing that when we're working with those that may have challenges with technology, or, if you're looking at something, they're saying, oh, well, print this off and mail it in. Well, not everyone has a printer at home. Not everyone has a computer they can use. So how can we assist them in being able to educate themselves about the different plans? So there's a lot of information out there, but again, it is plan specific and it changes. I don't know how often it changes. I should know that. But again, at least, let them know that these are there for them. And we do know that that most of this is going we know that it's underutilized. So, if you can help spread the word with that, that would be greatly appreciated. All right, so the next couple of slides are just dashboards that are available on the public facing side. So I get all kind of emails or text messages about, hey, do you know how many people are enrolled in family planning in the month of, in the fourth quarter of 2022? Or, there's always a whole variety of questions. So the next two dashboards are separate. So the first one, the one you see on your screen, is the North Carolina Medicaid Enrollment Overview Dashboard. So I accessed this dashboard for this presentation back on using February 1st, 2024 data. It is updated monthly. What you don't see on here are the monthly, or is where you can choose the time period that you want. But I asked it, okay, well, how many pregnant women were enrolled in Medicaid overall? And this is, you can sort by just about everything that's on this screen. So this is what I was looking at that particular time. So in February, we had 39,000 individuals enrolled in Medicaid for pregnant women. This is the breakdown of who was in what plan, what their race and ethnicity was. It showed that 93% of them were between the ages of 21 and 44. And the color chart at the bottom tells you by county where they're located. So again, great information, especially if you're just wanting to know generic information about what's happening across the state with that. And the links are there at the bottom. If you go to that website, it will actually give you access to this dashboard and to this one. This is the North Carolina Medicaid Expansion Enrollment Dashboard. And again, you can play with all the different variables. I happen to access this using data that was available on February 1st, 2024. And I wanted to know, of the expansion group, how many women were between the ages of 19 and 49. And this is the information I got based on those variables. And as you can see, it gave me numbers by month. It gave me their home county, and it gave me all the information down at the bottom, everything from whether they're rural or urban, their race, what their ethnicity was and what their age groups were. So again, if you're somebody who likes to look at data, these two tools are available to you on the public facing website. All right, so I am going to turn this back over to Rachel so that she can cover how this is going to impact the work that we've been doing in the postpartum space.
And I just wanted to take a quick moment. There was a question in the chat around whether the extra benefits Velma could cover IBCLC home visits. In my response, I just want to check that it was correct, is that these value-added benefits are things that you wouldn't normally be able to bill for through Medicaid. Like if you have anything that's billed to an NPI provider, like standard NC Tracks billing, you still would have to go through NC Tracks. So I would think IBCLC home visiting would have to be through the standard coverage of Medicaid. And
I believe so.
And then you'll share at the end a way that people could suggest things that Medicaid should cover. Okay,
Yep.
cool. And does anybody else have any questions about that? The value-added benefits are very specific things that like aren't standard medical care that would typically be billed insurance, but the plans have decided to offer it to try to promote the health of their population. If that makes sense. Okay. So North Carolina Medicaid postpartum extension was a win that we had back in April of 2021. Prior to knowing for sure whether or not Medicaid would be expanded in North Carolina. North Carolina was one of the first states to actually do this, which was awesome. The American Rescue Plan, at the federal level, offered states the option to extend postpartum coverage for 12 months. And this American Rescue Plan was for 5 years, and they would use a state plan amendment to do that. And so in 2021, a bipartisan legislature-led budgetary bill was passed in North Carolina. Allowed North Carolina to do this. And I think that's actually, I think it was November 18th, 2020, where it was signed, and then it went into effect. November 18th, 2021, and then April 1st, 2022 is when pregnant beneficiaries started receiving postpartum coverage for 12 months if they were enrolled in any Medicaid program that covered pregnancy and birth on or after that date. And April 1st, 2022, all individuals that were eligible for Medicaid due to pregnancy or postpartum received full benefits for that 12 months. Even if they had given birth before then, if they were still in that eligibility period, they would qualify. And Medicaid expansion removed, so that was the first piece, like we were definitely going to cover people for 12 months postpartum. And then when Medicaid expansion passed here recently, that 5-year limit was removed. And so this is now permanent policy. And the reason why this is important is because this was the first question I asked, like if we are going to expand Medicaid, why do we need postpartum extension? But it's very important because it allows less need for people who are dealing with a major life event to have to transition to decide if they're eligible. Basically, it means no lapse in coverage and no reauthorization of coverage, even if they have an income change in that period of time. So they're basically guaranteed coverage if they had it during pregnancy for that period of time without doing anything, and regardless of what else changes or doesn't change in their life. Next slide. So anybody that receives Medicaid under any program that covers pregnancy and birth, and all birth events are covered. So this includes cesarean, this includes ectopic pregnancy, miscarriage, molar pregnancy, pregnancy termination or abortion, and vaginal delivery. The postpartum coverage begins on the date that the beneficiary's pregnancy ends and will conclude on the last day of the month of their 12-month postpartum period. Beneficiaries will remain eligible even if changes occur that may affect eligibility, such as, like I mentioned earlier, the change in income or household family unit. Next slide. So there are a few exceptions. The individual can request voluntary termination. Obviously, if they move out of state, then they're no longer covered. Or if the local DSS agency finds that the coverage was determined incorrectly during the current recertification, or there was error, fraud, or abuse, and that the information was reported to the beneficiary. It is an exception for people who are only eligible for labor and delivery coverage. So this is our population that we call emergency Medicaid. They're not eligible for Medicaid typically because of citizenship and immigration status. And that coverage is really not to the person, it's to the hospital to provide the labor and delivery. So they still, unfortunately, do not have coverage postpartum. And then obviously if the individual dies, which is what we're trying to prevent some of this. Next slide. So this is just an example in 2019 of how this might impact the postpartum care transition. So one of the things that's really important to me with this postpartum extension is, are people using it to manage their chronic conditions to get their well care postpartum. So we had over 118,000 births in North Carolina 2019, and about 50% of them, 40% were covered by Medicaid, not including emergency Medicaid. And of those, 40,000 at the time had ongoing Medicaid at 12 months. So this was even before Medicaid expansion and postpartum extension. This was just many of our people in our state that have Medicaid during pregnancy are actually not at 196% federal poverty limit. They're actually quite low and were eligible even at the previous income eligibility requirement. So of those individuals who had ongoing Medicaid at 12 months, only 6,000 of them had, so less than 25%, had a well visit within the 12-month postpartum period. And of course, we recommend that everybody does. And some of our patients need to be seen even earlier, especially those who have hypertension and diabetes and substance use disorder and mental health disorders during pregnancy. So this is kind of what we're trying to help promote. And it's not just an issue of coverage, but that's a big part of it, because even with this coverage in this situation, still people weren't making use of the benefit. Next slide. There's a lot of barriers to postpartum care, and I don't think I need to speak to this group about those because I think you all probably know better than me and have taught me these in many cases, although I also learned about them when I had my own children. But childcare, transportation, work leave policies, you know, many people who get Medicaid and qualify for Medicaid are in jobs where they don't have childcare benefits, where they don't maybe making enough money to pay for childcare or have work leave policies, right? Also, people feel like they don't need this, right? We know one of the groups that is least likely to get postpartum care are those people who've had babies before and know what they're doing. And lots of different schedules, not just of them themselves, but their family and what all the things they're managing. And so there's still a lot of work to be done on these other barriers, but I think at least, you know, with some of these new Medicaid policy changes, we're removing barriers in coverage for many people, and not all people, right? Because we still have a significant chunk of our population who's not insured, and even despite income is not eligible for Medicaid. Next slide. So I just wanted to say a word about like what should be done at that comprehensive postpartum visit. And I call it an annual exam plus, you know, this is really, I think for OBGYNs, we don't think about it this way as much as we should, but this isn't a preventive visit. It's an opportunity to wrap up issues that might have occurred during the pregnancy and to really make sure people's preventive services have been done correctly. So we have a bunch of screenings that we do: blood pressure, mood disorder, intimate partner violence, substance use disorder, including tobacco, checking around sexual function, incontinence, and pap smears, right? So kind of making sure all those are up to date and done. Counseling is really important for patients around what happened during the pregnancy and delivery. And, you know, we have complications. I also think it's really important for providers to talk about, even if there wasn't a perceived complication, because there are so many times I say, hey, how did things go with your delivery? It looks like it went okay. They're like, they make a big face, no, it did not go okay. So there can still be a lot of trauma and unresolved questions for patients, even if the provider perceives that the delivery did not have any complications. Also just talking about long-term health implications of what happened. Breastfeeding and healthy lifestyle behavior are also important, as well as preventive services like offering contraception if desired and indicated, conducting immunization review and offering those vaccines that are needed. And then finally, arranging follow-up. So especially now that most of these people will have ongoing coverage, really having a discussion with them about how they're going to transition to primary care. And even for those people who don't have coverage, this is important because we do have some safety net providers, luckily, in our state. So making a plan with the patient, is it going to be that they come back to the OBGYN that they've been seeing for their annual visits, which might be completely appropriate? Or do they need to transition to a primary care provider because they have hypertension and diabetes that need management? Or do they need their primary care provider plus a mental health provider? So just really making that plan with the patient at that visit, so it's really clear to them who's going to be taking care of what and when they need to follow up with those people. Next step, next slide. Me, I'm losing track of the numbers. All right, I think this.
Yes, this is you.
Okay. So there can also be other access to care barriers. So does your practice setting provide a welcoming atmosphere to all persons in their interactions with the practice? And then do your practice discuss reproductive life planning and pregnancy and tenderness in a very open-ended fashion? Do you educate patients about the importance of early postpartum care, especially, you know, really for everybody, but especially for people with chronic with complications? Do you review pregnancy spacing recommendations with postpartum patients? scheduling considerations. Does your practice accommodate all of the patients in a timely fashion? Does your patient practice have a tickler system or an electronic warning system to flag when patients have delivered or when they've missed a visit? Do you offer telehealth, weekend or evening, extended access appointments for people who may be working a job 9 to 5 that they can't leave to come to an appointment? Are there opportunities to co-schedule appointments for birthing people and babies together, right? Like, so they can come to the same site if that's applicable for both of their appointments. These are all things that may help improve access to care.
Okay, so are there any questions in the chat that we can address at this point?
There have been some in the chat, but I think they have all been addressed.
Okay, great. Okay, so now that we have, so let's move into some data questions because we're always getting asked, well, how are we going to know if this is successful? So other states have seen success, but how does North Carolina Medicaid know whether the programming that we're doing is working or not? So the next 3 slides are just an example of some of the data dashboards that are being built behind the scenes to help us look at that. So as Rachel stated, we on Monday, on April 1st, we will be at our 2nd year anniversary for the 12-month postpartum extension. So we now can say we have data that we can review to see how we're doing, right? So one of the charts that they've developed is specifically looking at, how many individuals had a paid claim on most or moderately effective contraceptives within 60 days of delivery. So again, I can choose a variety of variables here. So I chose to look at those that had Medicaid for pregnant women. And what you'll see is that if you compare Medicaid for pregnant women with full Medicaid, what we know is full Medicaid, you'll see that roughly 37 to 38% of both groups had received some form of a most or moderately effective contraceptive. And so across the state, that was about 38% of the individuals. So, and that's, there is no target metric that we want to hit, right? Because individuals need to be able to decide for themselves what form of contraceptive they may want to use. They may not want to use anything, but this is interesting to Medicaid more so just to see where are possible deserts occurring across the state. We know that we have issues with access to all forms of contraception in all the counties, but this gives us a good snapshot of what kind of care is being provided across the state. And then one of the other examples we have is how many of the individuals have had a primary care provider visit within 6 months of delivery. Now, this could have been that they've gone to their OBGYN or to another primary care provider for some type of care within the first 6 months. And for this particular thing, I was looking again at just by race. I mean, so you'll see that on the left side, I was able to break that down among the different categories. And then across the state, I was able to see what that looked like. So our lowest, in one of our counties, we had only 43% of our members had seen a primary care provider within 6 months of delivery. And other counties, the numbers were as high in the low 70s. So again, we can use this data to share with the plans, and the plans have their data as well, but just to see where do we need to make extra efforts to ensure that that members are truly able to access the care if they need it. And then another, we have different time periods. We actually have like within 60 days, 3 months, 6 months, 12 months. I just chose a handful of things to look at. But I wanted to show this slide in particular because this is looking at the number of individuals who had a primary care provider visit within 12 months of delivery. And the difference and I sorted by MPW coverage, and the difference that I saw here was actually worrisome for me because it showed that about 53% of those that had Medicaid for pregnant women had a visit, but 78% of those that were outside of this program had a visit. So to me, that's significant. So when I was looking at this told me 2 things. Number one, from a provider perspective, there are probably still providers. So yes, we're about to hit that 2-year anniversary, but I'm always amazed when I'm talking to colleagues that not everybody enjoys reading about Medicaid as much as I do. So I do know that there are still providers out there who don't know that Medicaid for pregnant women is good for 12 months. So they may not know that they have the ability to help refer these members to other care. And then on the member side, as Rachel alluded to, sometimes when we have members who are now maybe on their 3rd or 4th pregnancy, if they had that 1st and 2nd pregnancy under Medicaid for pregnant women and it expired after 2 months, they may not have the information that it's now good for 12 months. So even though communication has gone out to them, there's still a disconnect. From my perspective, it looks like there's still a disconnect there between our knowledge base, even with our members. So what can we do? Both, I'm looking at you all in your community and in your interactions with members to continue that educational process, because this truly highlights the importance of repeating this information with every pregnancy, because benefits change and we need to make sure that we're doing our job with educating our fellow providers, but also our members that things have changed and these are the new benefits. So with that data, so what the data maps are showing though, is that we are struggling to present some of the data because of the way we pay for obstetrical care in North Carolina. We pay for bundled care packages, which means that Medicaid may get one charge for the work that's done during that entire pregnancy. So if you look at our specific data measures that are looking at our patient population or the population that we're here talking about, there are the prenatal and postpartum care HEDIS measures, and that's specifically looking at the timeliness of prenatal care and postpartum care. So Medicaid is working with the plans during 2024 to improve the numbers, to improve our numbers in this field. And we know it's related to data. So there are a variety of new postpartum billing codes that we want to introduce you today. One of them is just knowing that the obstetrical bundled codes are still the same, except that the VBAC, or the vaginal birth after cesarean delivery codes, have now been separated out and are billable under their own categories. This went into effect last summer, but still we want to continue to educate others that that is happening. The second item on here is the S code, which has been in place for a decade now. And so this S0281 is an incentive payment of an additional $150 if you complete that comprehensive postpartum visit that Rachel alluded to within 60 days of delivery. So by billing that code, that notifies Medicaid that somebody's had a postpartum visit. And then we're also introducing 2 F codes that technically went into effect on January 1st, but a clinical bulletin is being released on Monday, April 1st, that's going to give you full details on that. And we're excited about that because there are 2 codes that are going to help us pinpoint the beginning and end of a pregnancy. So one is 0500F, which is going to be that initial prenatal care visit with the obstetrical provider. And then the second one is the 0503F code, which is going to designate that you have completed that postpartum comprehensive care visit. Now, Team Medicaid has been working with our partners over at AHEC, and they've developed this great provider information FAQ document that will be released after Monday, but there is more information to come with this. But by implementing these 2 additional F codes, we hope that our data is going to get even better and better, so that when we're analyzing this, we'll truly have complete snapshots on when pregnancies begin and end. So I did include a couple of slides just for your information. There are many ways that somebody can enroll in Medicaid. What you see here are the 4 standard ways that they can enroll through the Medicaid process itself. The 5th way that began actually on February 1st. So if we have somebody that's enrolling through the federal market website, then by entering their information there, the marketplace can now look and see whether they qualify for North Carolina Medicaid. And if they do, that information is sent to Medicaid, and they are automatically, they will automatically go through the process and are able to bypass a DSS office. All right, so we know we've shared a lot of information, but I'm going to turn it over to Rachel to close us out here.
So what can you do? Encourage all of your uninsured or underinsured individuals to apply for Medicaid. Because at least they can get, some benefit, if whatever they're eligible for, they will get, if they apply. Help educate beneficiaries about expanded coverage and add-on benefits. This is really important. I just actually emailed our social worker during now because I was like, shoot, we really need to make this happen at UNC because I keep doing it individually for patients and I wish it was more systematic. Set up an automated system to capture all patients who have had a birth event and bring them in for follow-up or postpartum visit. Some of you know I've been working on that type of thing with a Cure for Moms, giving alerts to practices when a patient has missed a visit. This is super helpful. Encourage members to establish a primary medical home and to access medical care. And before, during, and after pregnancy, right? That one's like across all of it. And then educate other people about the added benefits, especially people who aren't used to taking care of patients in pregnancy and knowing that these exist. So I'll leave it there so we have time for questions.
Awesome. Thank you so much. That was really great. So yeah, do we have any other questions? I don't see any in the chat. We have recorded, so you all can watch this again if you want to review. Let's see, we do have a question.
I guess my question was kind of about if you weren't sure if you were eligible or if maybe you're in between categories. Are there other free options for people to consider to get care? And that's things I wondered about, like with mental health or lactation or doula support.
I mean, I think the short answer is that if you're not sure, you should still apply because you might, unless you're sure that, like if it's somebody who's doesn't have like the immigration situation, right?
Mm-hmm.
That's an issue. But if you're not sure, you should apply because you may be eligible for benefits. And I think aside from that, I think what I'm aware of is it are basically local and regional things like charity care at some of the health systems that can be applied for. I know there are multiple health systems in our state that offer charity care programs. I think there are also places like FQHCs and other safety net providers that offer care on a sliding scale. Our Title 10 clinics, for example, offer family planning care on a sliding scale, and you don't have to have insurance and it slides to zero based on your income. So, there's not like that I know of an insurance, option for those people. Obviously they can pay out of pocket for insurance plans if they could afford that. But there are safety net kind of things that fill in the gaps in regional places.
Awesome. Thank you. Any other questions? So, and just as a reminder that if you would like a nursing contact hour, please click the link. And also we would love to get your feedback for today as well. So before everyone jumps off, we have a few quick updates, and I think we have a minute to premiere our newest reel that's coming out.
I'm not sure we can. I'm not sure if we're still trying to fix an audio thing, but
okay.
We can tease it.
We can tease you with it. Okay, so anyways, this is the QR code for the evaluation. Next slide. So save the date. So April 18th will be our next session. And we are really excited to be focusing on Black maternal mental health. And we're going to be learning from Dr. Jasmine Garland McKinney. And this is part of concluding Black Maternal Health Week. And we're really excited about this. So we will send you an announcement about it, but make sure your calendars are marked for this upcoming event. Next.
And then we won't see them between. So I'll take this one, but I just wanted to make sure everyone was aware of some of the Black Maternal Health Week events. Of course, Black Mamas Matter Association has a list of local events and toolkits and resources for the week. And each day there's a different topic focus. and there's a different event happening surrounding the topic of the day. And it could be around policy or around International Day of Rights, things like that. But it kicks off on April 11th. And I wanted to share some local North Carolina events in case anyone was able to join. The South Piedmont AHEC is having a Black Maternal Health Conference in Charlotte on April 11th. So I can, in our communication with the recording, I'll be sure to have this information in there. Equity Before Birth has a community event, a fundraiser and a dance party in Durham. It's at the Museum of Life and Science from 4 to 7 on April 12th. And then the Mommy group has a fair and a walk on April 13th from 8 to 2. And this is just some of, there's many Black Maternal Health Week events. I saw Savia Waits doing a book reading and a launch with, I believe, Every Mother Counts. So there's a lot going on. So just be sure that you're following along, and Black Mamas Matter will be sending out more announcements about it. And then we're excited to be partnering with the Believe team to conclude the week with the webinar on honoring Black maternal health experts. As always, our previous sessions are on newmomhealth.com/community of practice. And reminder that you can, North Carolina sites can order toolkits. They're still up there, and you're able to order free postpartum care tools. The list is on the right-hand side where you can see the different tools that they will print and have shipped directly to you to implement in your practice. These were all based on the ACOG guidelines. So hopefully, helping to improve communication and streamline care services. As Sarah mentioned, we have some more new reels coming out, launching. If you missed it, I don't think we ever were able to show our reel on pain management. So Sarah, if we do have a minute, I'd love to show this one. This was part 3 of our Taking Care of You postpartum health series. And this one's talking about, tips for recovering with pain after childbirth. And then the one that we'll be launching in the next week or so is on breasts.
Awesome. Well, any questions? So maybe we can unspotlight Rachel and Velma.
Yeah.
And what we can do is, while you are clicking on your evaluations before you sign off, why don't we go ahead and let you all see the pain video. It's only 2 minutes, so here you go.
Can you hear?
Nope. Can't hear. I'd like to say that the results of our candy poll highlighted Starburst jelly beans and chocolate. Okay, go ahead.
Hey, it's Nurse Nikki, and I'm back to talk to you about taking care of yourself during the postpartum period at home. In videos 1 and 2, we cover
come see our cool video.
Or contact a healthcare provider. Here, we're going to talk about recovery and managing your pain. Let's get into it. Following birth, apply ice packs or padsicles to your bottom to help with pain and to reduce swelling. You can make homemade padsicles by applying aloe vera and alcohol-free witch hazel to pads, then freezing them. After a day or so, warm compresses or soaking your bottom in warm water can feel soothing. Consider using a squirt bottle of water as you pee. You can also use it to cleanse the area after you pee. This will reduce any stinging to tears in that area. Prevent constipation and hemorrhoids by drinking plenty of water, eating fiber-rich foods like veggies and fruits, and taking a stool softener if you need it. Bleeding after birth, called lochia, is normal, and quarter-sized blood clots are common the first few days. Bleeding should lighten and taper over a few weeks. Change your pad regularly to keep fresh and watch for any unusually heavy bleeding. Bleeding through a pad an hour is an urgent matter, and you should contact your healthcare provider. If you've had a C-section, stay on top of ways to manage your pain, such as taking your pain medication prescribed by your doctor. A number of nerves are cut, and you may feel a burning or tingling sensation as they heal. This is normal. Use a pillow to brace against your incision if coughing or sneezing. Don't try to lift anything heavy. Remember to be gentle with yourself and move slowly. It can take months for the incision area to feel normal. If you've delivered vaginally, it is still important to use your pain medications such as acetaminophen, Tylenol, and Motrin or ibuprofen to help control pain and cope. I hope these tips help in your recovery journey. You will feel better, and you matter.
Thank you, Suzanne. So those are all free and you can use them. We hope you'll use them. Thank you for joining us. Happy spring.
Thank you
Go
again, Dr.
Carolina
Urrutia, Dr.
basketball,
Taormina.
whichever North Carolina team you're supporting. Thank you again, Rachel and Velma. And we hope you all have a really great rest of your day.
Take care.